Hello, this is Dean Wingerchuk. I'm a neurologist at the Mayo Clinic in Scottsdale, Arizona, and I'm going to talk with you today about NMO spectrum disorders and whether we're getting closer to a rational pharmacotherapy. The material that I'll present today comes largely from the recent ECTRIMS meeting held in September 2016 in London. My objectives are to review some of the abstracts and presentations from that meeting that are relevant to progress in treating NMO spectrum disorders. One of the key presentations at the meeting was by Professor Kazuo Fujihara from Japan, who provided an overview of the diagnosis and management of NMO spectrum disorders as we currently conceptualize them. Under the current diagnostic criteria, the disorder is stratified by the ability to detect or not detect aquaporin 4 antibodies. Aquaporin 4 antibodies are found in about 70 to 80% of people who meet the NMO-SD phenotype. These patients probably have a primary astrocytopathy because this antibody that targets aquaporin 4 appears to be pathogenic, and there's many lines of evidence to support that it can destroy astrocytes which express this antibody in humans. Professor Fujihara also reviewed current therapeutic approaches, in particular emphasizing that in this disease we need to avoid the use of multiple sclerosis disease-modifying therapies because they probably aggravate the disease, most particularly beta interferons and natalizumab, and that observational evidence suggests that general immunosuppression benefits the disease as far as reducing relapse frequency and severity. And this would include generally available therapies such as corticosteroids, azathioprine, mycophenolate, methotrexate, and less commonly mitoxantrone. In particular, though, there are targeted therapies that are increasingly being used when available or studied in randomized controlled trials. And these would include things like rituximab, anti-CD20 therapy, tocilizumab, which is a interleukin-6 receptor inhibitor, and eculizumab, which is an inhibitor of complement. Anti-CD19 therapies, which deplete B cells, are also being studied. Dr. Fujihara also discussed the current status of controlled trials for NMOSD. There are not any therapies that are currently approved by the FDA for treatment of NMOSD in the United States, but there are ongoing clinical trials. He discussed the recent controversies and debates regarding design of clinical trials, whether or not placebo-controlled designs should be used, and how to mitigate risks in current studies, such as using time to attack as a primary outcome, limiting the duration that a patient or a subject in a trial might be exposed to placebo by having an early escape, for example, after a single attack, unequal randomization, and using futility analyses to adjudicate outcome. We've got, at present, 3 large controlled studies that are ongoing, including a placebo-controlled trial of an anti-CD19 therapy and add-on designs for investigation of other agents. Dr. Jackie Pallas from Oxford, in a parallel session, discussed an emerging concept in NMO spectrum disorders, and that is the potential role in some patients of MOG, antibodies to myelin oligodendrocyte glycoprotein. There were also a series of abstracts at the meeting, including several by Sven Jarius from Heidelberg, describing this apparently distinct syndrome. It turns out that roughly 25% of patients who have an NMOSD phenotype but who are negative for aquaporin 4 antibodies will be positive for antibodies against MOG. The clinical phenotype of these patients may differ slightly. They tend to have more commonly detectable lesions in the conus or lower thoracic cord, bilateral simultaneous optic neuritis, or an ADEM-like phenotype with brain MRI lesions showing gray matter abnormalities. MOG antibodies seem to disappear in a minority of patients, and it's still being worked out what frequency of these patients actually relapse, although some of the data from Sven Jarius' paper suggest that most patients actually do. These findings are important because we're hopefully moving towards a better way to biologically categorize patients who have an NMOSD phenotype and understand them better on a pathologic basis. So the argument here is made that aquaporin 4 positive disease is a primary astrocytopathy, whereas the MOG antibody patients have a primary demyelinating disorder. Ultimately, targeted treatments for these disorders may be different. Moving on now to some of the new data regarding treatment of NMOSD, there are really two areas of treatment for the disease. One is treatment of relapses or attacks as they occur, and the second area is prevention of those relapses in the first place. In the realm of treating attacks, Ingo Kleiter from Germany presented data regarding a retrospective study of over 200 attacks in 105 patients treated with plasma exchange or immunoabsorption. So typically, patients who are having attacks would receive a course of IV methylprednisolone and then potentially rescue therapy with plasma exchange. And in some of their German clinics, instead of plasma exchange, they used immunoabsorption. Now, in this study, they looked at the relationship of these various treatments to complete recovery, partial recovery, or no response to these interventions. They found that patients who had a complete response more likely received plasma exchange or immunoabsorption as a first or second line therapy rather than a later line therapy, were much more likely to be positive for aquaporin 4 antibodies, and there was an association with reduced time from attack onset to start of therapy. That is, the more quickly plasma exchange or immunoabsorption was initiated, the more likely they would have a complete response. This study adds to a growing body of work suggesting that not only are plasma exchange and immunoabsorption likely to improve outcome from acute attacks, but the earlier they're used, the more likely the person is to get a complete response. And this probably will lead to some further investigations of earlier therapy, hopefully in controlled trials. Now moving on to relapse prevention, there's some new data from Kim and colleagues, a study of IVIG for relapse prevention. This is something that has certainly a rationale based on how we understand the immunopathogenesis of aquaporin 4 positive disease to be humorally based. They studied 35 individuals who had IVIG infusions with varying frequency for a median of 3 years, and they showed that there was a reduced annualized relapse rate and EDSS stabilization or even improvement in 77% of patients. However, only 34% of these patients remained completely relapse-free. They thought that further evaluation of IVIG for relapse prevention was warranted. In this next slide, we show summary data from a study of mycophenolate used as first-line therapy. So this is one of the therapies, probably along with azathioprine and rituximab, that's most commonly used in this disease. But as a first-line therapy, we don't have very much data. This French study was a retrospective review of 67 individuals treated with mycophenolate as a first-line treatment. Half of them were relapse-free at last follow-up, with a reduction in the median annualized relapse rate from 1 pre-treatment to 0 post-treatment. EDSS improved or stabilized in 83% of patients. And interestingly, they were able to show that the effect seemed to be evident in patients regardless of their serologic status. So that is NMO-SD with or without aquaporin 4 antibodies, and even in a few MOG patients. This next slide shows some summary data from a comparative efficacy study from Germany. Stellman and colleagues retrospectively evaluated 150 patients with NMO spectrum disorder that had received over 300 treatments, a mean duration of which occurred for more than a year, about 440 days. And they found some general themes. One was that patients who had aquaporin 4 antibody disease had a very high risk of relapse, much higher, about threefold compared to the seronegative patients. Second, patients who had relapses under a current treatment were likely to have a relapse again if that treatment was not changed. And they also showed that over time, relapse frequency declined. For every decade of disease, the hazard ratio was 0.76. So that seems to be part of the natural history of the disease. Overall, they compared the use of azathioprine and rituximab relapse rates to that of interferon therapy as a baseline and showed that both were in fact favorable. One could perhaps argue with the use of interferon therapy as the reference baseline because interferon may actually aggravate the disease, but nevertheless there was a clear difference between these immunosuppressive regimens and interferon. This next slide shows data from Italy looking at the use of rituximab. Rituximab is one of the most commonly used therapies for this disease as an anti-CD20 B-cell depleting therapy. In this study, they looked at 40 individuals with a mean follow-up of nearly 4 years, and they found that 60% were relapse-free, but if they were fully B-cell depleted, as evidenced by CD19 depletion, then they were even more likely to be relapse-free, about 80%. But here they point out that if one is aggressive with rituximab therapy with complete B-cell depletion, there's a risk of getting leukopenia or low immunoglobulins, and this is associated with serious infective adverse effects. So what this study highlights is the need for better therapeutic biomarkers where we can balance the benefit and the risk of these very powerful immunosuppressive therapies. Along those lines, this next slide shows a separate study from Italy looking at the relationship of aquaporin 4 antibody titers with disease activity and with rituximab therapy. What these investigators found was that aquaporin 4 antibody titers do correlate with clinical relapses as compared to remission, so the titers go up just before and around the time of relapses, and you can reduce titers by treating with rituximab. However, the results are not really robust enough for routine clinical use. So at this point, it seems that aquaporin 4 antibody testing is extremely valuable for diagnosis, but probably not as useful for individual therapeutic monitoring. And this is something, again, that we really need in the field. Finally, in the realm of MOG-related NMO-SD, Jarius and colleagues provided some initial data suggesting that similar treatment approaches for aquaporin 4 antibody disease work for MOG-related disease, that is, IV methylprednisolone or plasma exchange for acute attacks. They note that flare-ups often occurred after steroid withdrawal, which is something we see in aquaporin 4 positive disease, and they showed that immunotherapy with azathioprine, methotrexate, or rituximab seemed to be associated with reduced relapses. In conclusion, we're making good progress in the nosology and the treatment of NMO-SD. It does seem that a proportion, perhaps 25% of patients who are aquaporin 4 seronegative, in fact have MOG antibodies and a different disorder. We're getting better at understanding treatment of attacks, and earlier use of plasma exchange is an emerging theme. And in preventative therapies, general immune suppression and targeted immunotherapies are now being studied in randomized controlled trials and in large prospective observational studies. And the better we understand the immunobiology and the pathology of these disorders, the better we will be able to target therapy. Thank you very much for your attention today.